Today's discussion will be presented in 3 sections since we are recording it for a radio broadcast on Federal News Radio 1500 AM. You're welcome to post questions and comments during the session, and we'll try to answer them online. I'd like to introduce our moderator, Jason Miller, Executive Editor of Federal News Radio 1500 AM and federalnewsradio.com.
Welcome to the discussion. My guests today are Colonel William Baez, the Chief Medical Information Officer in the Office of the Air Force Surgeon General; Andrew Jacobs, the Technology Strategy Branch Chief for the Defense Health Agency; Wayne Bobby, the Vice President for Infor Federal; and Beth Myers, the Chief Nurse Executive and Analytics Strategy Director for Infor. Welcome to the panel today.
Thank you.
Thank you.
Before we get started, let me set some context for our discussion. The federal government's opportunity to change the way healthcare is delivered and consumed is immense. The Defense Department treats about 9 million service members and their families per year. The Veterans Affairs Department provides medical services to about 6 million veterans annually. Add to this 15 million the citizens served by the Indian Health Service, the National Institutes of Health, the Centers for Disease Control and Prevention, and a host of other agencies, and soon you can see the federal government's opportunity to change the way through technology and innovation how healthcare is delivered to all citizens. Market research firm Deltek estimates agencies will increase their spending on commercial health IT products and services to $6.4 billion by 2021. That's up from $6 billion in 2016. Deltek says DoD and VA are driving the spending increases through the new electronic healthcare systems, as well as the broader digitization of processes and integration of data across the federal healthcare sector. The move to the cloud, the rise of better and faster data analytics will drive broader adoption of telehealth and mobile applications for healthcare providers as well, according to Deltek. These technologies can help hospitals and clinics gain a complete view of any one patient to ensure the service member or veteran or citizen more generally receives unique health care and makes the most of existing data, systems, and processes. The challenge, however, is immense as well. Many healthcare organizations face, public and the private sector, a tangled mess of systems and databases that have grown up over the last 20 years. This makes data integration and sharing much more difficult. Right behind the challenge is the amount of data healthcare produces. Right behind that challenge is the amount of healthcare data that is produced each day. IDC Health Insights estimates more than 25,000 petabytes of health data will be created by 2020. So how can patients and healthcare practitioners manage, understand, and make better use of all this information? These challenges must be overcome to reach the end goal of all of these efforts, which, like most IT transformation efforts, center around lowering the cost of care, improving patient outcomes, and improving patient experience. So how do we do this? How do we accomplish this challenge? Well, that's where our panel comes in. I'm going to turn with Colonel Baez to start. We learned earlier in our conversations that you just returned from Korea, so you bring a multiple kind of perspectives. So let's talk about technology. Where does that fit in improving healthcare? Give me your, from the Air Force Surgeon General's perspective.
Thank you, Jason. So obviously our hope when we finish with the deployment of the health system is to be able to serve the thousands of service members deployed around the world in a variety of missions, and it's imperative for us as the DoD to have an advanced information technology platform that's agile, reliable, and secure so that we can fulfill our primary job to move patients. So our goal is to leverage the cutting-edge technologies that exist now and make processes safer and more efficient so that we can bring our members home to their loved ones. The biggest challenge that we've got, to paraphrase what General Edgar has said in the past, and he's the Air Force Surgeon General, is that we're always trying to maintain a ready medical force. We're taking more advanced care into the operational environment than ever before, and that requires us to have deployable teams with very sophisticated capabilities. So, as you said, the challenge is to keep those teams current and ready to deploy at any given time.
It's interesting you talk about the platform. We're talking about Genesis, to be clear, or is there a different platform we're talking about?
It's actually the same platform. Sometimes when we talk about MHS Genesis, we talk about a system of systems. And so the operational medicine or the readiness environment, which all services have a hand in, are looking forward to the advantages of having the MHS Genesis system completely deployed, so that we can actually record care from the point of injury all the way back to the hospital in the United States.
And then, of course, we have the news from the VA that they're going to be very close integration with DoD, so you can pass when the person becomes a veteran, when they leave the service, then that information is passed easily as well. So I know that's all in the long-term view.
Yep, very excited about that.
Wayne, let me turn to you. Infor's perspective, you guys are working in the public sector, you work in the private sector. What are you seeing around where technology's role in health and improving healthcare?
Sure, great question. So at Infor, which is roughly a $3 billion privately held software company, Infor has had a great deal of success in the commercial healthcare business over the years. In fact, Infor maintains today about a 72% market share when you collectively look at all the solutions we provide, whether it's in the back office with ERP in a hospital, financials, human capital management, supply chain, whether you're looking at the interoperability of all patient care and patient records that exists, any workload requirements in terms of workforce management, issues that may exist in terms of make sure that all the right clinicians on staff at the right times to serve the needs of your patients. So Infor looks at all of that, and we've been very successful at that in commercial healthcare. And my challenge here at Infor with our federal business is to bring those solutions that have been so successful in the commercial world in healthcare into the federal government. So as Colonel just spoke, and I'm sure as Andrew will speak to here, they're looking at other customers that have been successful, and not looking at other federal agencies necessarily, looking at commercial hospitals and commercial healthcare providers and insurers in terms of what they've done. So we want to bring those solutions into the federal market and make sure people are aware of those people that maybe are a step ahead of us or are a step ahead of what we're trying to accomplish today. How can I look at other best practices and how they might make sense for us here in the federal space?
There's two things going on here. You have the commercial world and you have the public sector. A lot of what's happening in both sectors kind of overlap. Is that where the technology makes the most sense? Meaning, hey, when you take an X-ray and that X-ray needs to be transported through telehealth, and I'm just kind of pulling that example out. That's the coordination that you see. Meaning, one good approach works in both sectors very well.
Yeah, that's what we find to be true. So we've started to have some success in the federal space. We have some solutions now at NIH that have proven to be very successful. We're doing this across a number of public sector hospitals in states, cities, counties across the country that make sense. And again, we want to look in terms of how those things can apply in the federal space. You bring up telehealth, where the challenge is how do we get service, for example, or patient care to people who could be in very remote locations across the country, right? How do we reach those folks, and how can a doctor keep track of all of those patients and make sure we understand what their vitals are? We're looking at in a world today with technology where you have Apple Watch devices, or people are online with Garmin devices, those sort of things. How can we use that technology so we can know wherever Jason might be, okay, can we reach him, can we understand his vitals? What is that today? Because he may not be able to travel the 100 miles to get to the local VA hospital.
There's a great story. I know former CBP Chief Technology Officer, he may still be there, Wolf Tomby, used to talk about how an Apple Watch can help with people on Border Patrol. If they're in the remote area, you would know what's happening based on their heart rate. If they get a spike in heart rate, maybe something's happening. Andrew, let's talk about Defense Health Agency a little bit. Colonel Baez talked about the platform. Talk a little bit about what's going on at DHA around technology and health IT.
Good question. So from our perspective, from the technology planning perspective, we have to look at the technologies as far out as about 10 years. So we don't kind of have any surprises that may come down the road. So for the past few years, when we formed as a Defense Health Agency, we produced what we call our LRTA, or our Long Range Technical Architecture Plan, which kind of gives us a focused look at the different technologies that we can look at bringing in our enterprise to reduce cost and improve healthcare by leveraging a lot of the advanced technologies that are being produced by industry. A lot of this does pertain to our garrison experiences here, not necessarily in theater, but a lot of the technology can be used in theater as long as we get it on the right ruggedized platform to actually get used out there.
So when you talk about the long-term plan, is it updated every year? Is it updated every 3 years? And can we find it on the internet yet?
Yes, you can actually. In any of my emails, there's a HTML link that'll take you there, and you can download the plan. It's accessible to anyone that can hit our webpage and download it and read it. It's about a 60-page document, and we update it. We update the technology inputs about every 2 years, because when you start looking at those different waves of technology and the technology maturity, we have to kind of advance it along also, and there are also changes out there. So when we first developed the plan, blockchain was not big.
Right.
It wasn't a big thing. So now blockchain is starting to emerge as a technology that a lot of people, especially in the medical community, is starting to look at, so you can keep kind of that provenance of the data within its ledger. So, you know, being able to add it and adjust it about every 2 years. This is a dynamic long-range architecture document, so it will change, and we can actually change it quite quickly if our strategies change or if new functional gaps appear.
It's interesting when you start talking architecture, you always worry about people getting eyes glazed over, but it's really the basis of any technology is getting their architecture right. Is that hard every 2 years to change it, because things can change in 6 months or in 3 months? You said it's a dynamic document, so imagine that as things happen, you don't wait for that 2 years, you update as appropriate?
Yes.
I'm guessing, maybe I'm wrong.
No, we update as appropriate, and we still narrow down the technologies, because when we first did this, there was about 3,000 technologies we were looking at tracking that had a positive impact on our enterprise. However, you can't implement 3,000 technologies, so what we did is we narrowed it down by what's going to meet our strategic goals faster and what's going to close our functional gaps quicker. And we were able to actually narrow it down to 33 technologies we needed to implement over the next 10 years to meet 100% of our goals and close about 98% of our functional gaps.
Wow, it must have been a heavy lift to go 3,000 to 33.
We've expanded on it too. So,
Sure.
So in the beginning, like I said, we were tracking 3,000 different technologies. We actually use an analytics tool to do this because no one person could do that. Now we're tracking, because we've added more data when it comes to actually academia and it comes to other inputs. We're tracking about 400, 500,000 different solutions to those technologies.
Interesting. Beth, you bring the practical experience as a nurse. You bring the technology experience a little bit too, hopefully, or a lot. Talk a little bit about what you're hearing from the panel so far in terms of technology and the impact it has on healthcare and today and going forward.
I always like to sum up the technology and why I'm interested in technology in decision making. So I've used my experience as a veteran and my experience in the Army Nurse Corps to focus on expertise and decision making. I'm actually using my GI Bill money right now to go back to school and finish my PhD in informatics. Nice. Wish me luck. It will. It's been a long road. But my focus is really on expertise and decision making, and so I see technology plays a key role there in a couple places. One of those places is from the experts. Experts make decisions based off of their own personal experience, and when they're in situations that are high pressure situations, as you frequently see in military situations or other places in the DoD, we need to be able to provide information to those people in real time. So if that's a forward surgical team who's trying to make decisions about what's the best care for this patient when they're out in the field doing emergency surgery, I need to know that patient's entire medical history if I possibly can. And on the other side, technology is also good at getting that information so we can document it in one place, relieving the burden on the clinicians for documenting more than one time. In order for that to be successful, I like what you said, Andrew, about blockchain. I think it's really interesting to be able to track that data provenance, but you have to have accurate documentation at that first point in order for it to be good data. Last time I was in the doctor, I know that he documented something wrong. He gave me my care sheet and he said, oh, I said that is not accurate at all. Should I fight him? Oh, it's exhausting. I already have my stuff, I'm going. But you know, it's in my medical record and it's erroneous information. So if we don't have the good, if we have good information, we should be able to document it one time and then feed that information to whoever that is it's relevant for decision making throughout the organization.
I like that, expertise and decision making, because they're related, but there are very two different things. Talk a little bit about what you're seeing in the federal sector. Are the services, whether it's VA or DoD or whomever, moving in that direction yet, or is that still fairly new?
I know that the military is very interested in expertise and decision making in general. As I come across my work for my studies, there's a lot of people who do studies in expertise, especially when it comes down to battle decisions and those heated decisions. I think that hasn't been studied very well in healthcare yet in general. So physicians and expertise, there are a couple books about how doctors make decisions. And some literature in that area. There's some nice work around nurse and decision making, and we're starting to incorporate and study how those experts make decisions, how a NICU nurse can tell that that baby is going to go bad or going to have a bad outcome before the physician knows, before the labs come back. And we've incorporated those, studied that, and are bringing those back into computer IT algorithms so we can try to predict that and capture that expertise.
Andrew, you were shaking your head a little bit when Beth was talking about the decision making and expertise. Talk a little bit about what you're seeing or where you guys are heading in that way.
Well, definitely that's one of the keys to help us increase, care results and bring kind of best value to care, because doctors, physicians, nurses, anyone who's a care professional, a lot of times they have all of the training, they have all of the knowledge, but they don't have all of the information. And any type of decision assistance for them is going to be extremely helpful. So when they're looking in the health care record and they're basically saying, okay, I'm going to issue this type of drug, if you don't have any kind of assistance in that, you may not know that that's contraindicated with a lot of the other things that they're doing. So, when you're kind of developing a system or you're using those type of care assisted systems, an alert come up and say, do you really want to give this drug because they're also on this and this, and you may have a reaction here. You might want to try this drug. So.
Beth, jump in real quick.
Yeah, it's funny that you give that example. I have some colleagues actually who did their PhD thesis at the VA Minneapolis, specifically around medications pre-op and which medications you should start or stop right around the time that they have that operation. So it's being implemented in the healthcare in the federal area.
Interesting. Okay. Sounds to me like we're connecting some dots here, but we're going to take a quick break, and when we come back, we'll talk about the whole connection of dots. You're listening to the panel discussion, RX for Federal Healthcare Transformation through IT, sponsored by Infor on federalnewsradio.com and 1500 AM.